good afternoon from beautiful Pittsburgh, and good morning for everybody else who's west of us. It is my pleasure and honor to introduce Dr. Brad Dicianno. Dr. Dicianno, also known as Dr. D to a lot of us, is medical director for the University of Pittsburgh Medical Center Adult Spina Bifida Clinic and the SBA Associate Medical Director, and he is one fabulous doctor. Welcome, Dr. D, and take it away.
Thanks, Monica. It's so nice to be with everyone today. And I just wanted to start by saying thank you to everybody for taking time out of your Saturday to be with us. And I hope that you learn a lot of new information today. Let's jump right in. Let's go to the first slide. So one thing I wanted to start with is to talk about spina bifida and aging. We know that there are some conditions that are progressive, some conditions that aren't progressive. And spina bifida is a unique situation because it's not a progressive condition, but we do see effects of aging that are cumulative over time. So I created three little graphs here. The first graph shows the general population. So these are people without disabilities. Their neurologic function may stay relatively stable over time, but they may have some decrease in function from aging and medical complications along the way. The middle graph is spina bifida, where you may be born with some neurologic problems, which remain static over time, but you may have a progressive and steeper decline in function due to the cumulative effects of aging and other medical complications. And the third graph shows a progressive condition. This would be something like multiple sclerosis, where neurologically over time, the nervous system can progressively decline. And then you have the cumulative effects of aging and medical conditions on top of it. So hopefully that gives you a framework for thinking about spina bifida as really a condition that's not progressive, but does see effects of aging and medical complications over time. Next slide. So a lot of people ask, why do adults with spina bifida end up being hospitalized? We know this happens a lot. And by our research, we know that there are three big reasons why people, especially adults with spina bifida, are hospitalized. The first are urinary tract infections. And we'll talk about this in depth a little bit later. But we know that sometimes people are diagnosed with urinary tract infections in the emergency room and admitted for it, and they turn out not to be really UTIs at all, that it was really due to something else. But some of these are real UTIs as well. The second reason are devices. So this is complications from shunts, or some people who have indwelling catheters. Those make up the second reason. And the third reason are wounds, so skin breakdown. We know that about a third of hospitalizations could potentially be prevented in adults. If we do better self-management, if we provide better care in our clinics, we might be able to prevent a third of these, and that's pretty astounding. And these preventable conditions happen most often in those aged 18 to 51. So around that transition time up through, early 50s. And some of these preventable conditions can even be life-threatening. And we'll talk a little bit about those and what you can do about it. Next slide. So what are preventable conditions? So urinary tract infections to some extent can be preventable in some cases, and we'll talk about that in a bit, as can infections of indwelling urinary catheters, pneumonia, pressure ulcers, osteomyelitis, which is infection of the bone, which occurs when there's a wound that's been left untreated for a while and the infection gets very deep. And then there's sepsis, which is infection that spreads from one of these types of infections, and it spreads throughout the whole body. Next slide. People with spina bifida especially adults, are 2 to 18 times more likely to be hospitalized for infections compared to people without spina bifida. And this little graph will show you the different types of infections. So taking UTIs and pneumonia, for example, you can see based on age group that some age groups have very high rates of infection compared to people without spina bifida. So UTIs, for example, for those age 18 to 39, those folks are 18 and a half times more likely to be hospitalized for a UTI than 18 to 39-year-olds who don't have spina bifida. Next slide. What are the top 3 reasons for hospitalization of people if we divide it up by age? So we talked about the top 3 reasons overall, but let's break it down by age for now. The 18 to 35-year-old group and the 36 to 50-year-old group are very similar. And those are the 3 top reasons that I talked about before: UTIs, shunt and catheter issues, and wounds. However, the 51 to 64-year age group is unique. This group gets hospitalized a lot due to back problems. So if you look, you can see spine arthritis, degenerative discs in the back, and back pain. And some of these are not spina bifida related. Some of these are degenerative. These are potentially problems that are affecting people in this age group because of aging. However, there is also a group of individuals who have back pain related to spina bifida specific problems like tethered cord, for example. And then we have the 65-year and up group. This group is also unique. They tend to be hospitalized for more medical reasons. So pneumonias, anemias, heart failure. I also put some little stars here to indicate that although not in the top 3 reasons for hospitalization, stroke is also common in those 65 and up. And also 42% of those 75 years and up are readmitted again within 30 days after they're hospitalized and discharged. So they're in the hospital, they go home, and 42% of those people will end up back in the hospital within 30 days. So that's pretty significant and says that, we can be doing a better job at taking care of ourselves and also providing care in the clinic so this doesn't happen as frequently. Next slide. So let's talk about back pain, since this affects that middle group so commonly and really is common in all people with spina bifida. And one thing that you should be aware of, and a lot of physicians don't understand this, you can educate them about this, is that back pain can be spina bifida related in people with spina bifida, but sometimes it's not. Sometimes back pain is just related to aging in and of itself. So how do you figure this out? Well, first of all, you need a good neurologic exam. You need to see someone who can test your muscle strength, test your sensation, test your reflexes, someone who has a good understanding of how to diagnose a problem based on the symptoms that you're describing, the physical exam findings that they're detecting, and then they'll do a workup to figure out what is actually causing the back pain. We can't always just assume that the back pain is related to the spina bifida. There may be something going on that's treatable. So today, throughout the talks, there's a major theme of how to find specialists. So let's talk a little bit right now about how to help you find specialists who can help with your back pain. So who are some of these people that would be good to see? So one obviously is a neurosurgeon. These specialists can do a good neurologic exam, do the appropriate workup, and often they're very helpful in determining whether you have a spina bifida related issue like a tethered cord or a syrinx that's causing your back pain. Orthopedic surgeons can also be helpful. The types of conditions that they can generally help with is when you have pain related to scoliosis that's really severe, so that's spinal curvature. Some people also have spinal stenosis, which is a type of degenerative arthritis of the spine that affects people without spina bifida too. And some people have problems with the discs in their spinal column. So orthopedic surgeons can help with all of those. Then there's physiatrists. That's what I am. A physiatrist is a rehabilitation physician. Some people call them physiatrists, and it can be confusing because it rhymes with psychiatrist or podiatrist. But this is a unique medical specialty where we treat people without surgical interventions. So this would be good if you have some sort of like a back injury that ends up being non-surgical. We can also do a good neurologic exam and some testing to determine, what is causing your back problem and refer you to a surgeon if necessary. And then there are also interventional pain doctors or pain specialists. And these pain doctors are sometimes rehab doctors or physiatrists, or sometimes they're anesthesiologists. And these doctors can treat back pain with procedures that aren't surgery, but they're procedural injections and other types of interventions that are a little less invasive than surgery. So they can address things like disc problems, degenerative conditions, and what we call like pinched nerves from where the nerves are coming off the spine. So a good way to start is seeing one of these specialists to help try to tease out why you're having this back pain to get you the right treatment. Next slide. Let's move on to wounds. We need to think about all the different causes of wounds. Next slide. There are lots of different causes. One of the most common that we know about is pressure, but some other things that we need to think about are shear, temperature, and nutrition. So let's talk about pressure first. What are some things that you need to be aware of to reduce pressure on your skin? First, everyone should be doing daily skin checks. You should be able to look at your skin, and oftentimes when we have a difficult time seeing parts of our body, there are ways that we can still see the skin by using a long-handled mirror that are pretty inexpensive. You can get them at stores like Target or Walmart or some pharmacies. Also, some people have suggested finding non-latex stickers and having someone put them on your skin and having you see if you can find those stickers. If you find all of them, then you know that you are able to see those parts of your body. But the stickers that you haven't found give you some clues as to where your skin might be vulnerable, because those are places that you can't see very well. Other things that you can do to reduce pressure are to reduce pressure in your bed by using an air mattress or an overlay mattress, making sure your braces fit very well. Check those often and have them refitted or refabricated if needed. And then also in your wheelchair, make sure that you're using a wheelchair cushion that is appropriate for pressure relief. A lot of people don't know that foam that's inside of wheelchair cushions breaks down very quickly and can be broken down within a year. So oftentimes a foam cushion needs to be replaced very quickly, and it won't last the full 5 years of your wheelchair. Even higher end cushions sometimes only last about 2 years, so those have to be replaced often. Use your wheelchair cushion when you're sitting on other surfaces. Think about when you're in the car, when you're in an airplane. Also think about other surfaces that might be hard that you sit on, like a toilet or shower bench. And if you have a power wheelchair that has power seat functions that allow you to tilt back, use those often, because that really gets the pressure off your backside. Next slide. Shear is another cause of wounds, and shear means friction. So that's when your body slides across the surface. And some common places that shear comes from are your braces when they're not fitting well, often when the braces are too big and they rub across your skin. And then transfers. People oftentimes scrape their skin when they're transferring over their wheelchair tires. They get friction from the floor, or they get friction from the edge of their bed or a chair. So pay attention to that. And sometimes transfers can be done in a different way to prevent this. Next slide. Moisture. So this is a third cause of wounds. Moisture comes from our bladder, so it's important to get your incontinence under control and see a urologist, be on a good bladder regimen. For men, there are options to wear an external catheter at night. These are sometimes called condom catheters. They slide on externally and they can be used to catch the urine at night. This isn't a replacement for catheterization, but is one way to be able to potentially stay dry. Also, moisture comes from bowel incontinence, so it's important to work on your bowel program. If you can improve your bladder and bowel control to the point that you don't need undergarments, especially diapers that are full of like plastic, that plastic traps in moisture. And so if it's possible to get your bladder and bowel under control so that you can wear moisture causing undergarments. That will also help the skin. When you sweat or when you get wet after bathing, make sure that you dry the skin quickly and you don't sit in that moisture for a long period of time because it can damage the skin. Next slide. Temperature. So high heat can also cause wounds. And where did this come from? So high heat can come from burns. So some common things that we see in clinic that cause burns are food containers. So like if you microwave a food product and then you put it on your lap and you can't feel that container being hot, it can burn your skin. Pizza boxes, laptops and laptop chargers, hair dryers, hot packs and heating pads, sometimes used in physical therapy. These are all really common sources of burns, so pay attention to those. Also, sunburn is pretty common, and a lot of people don't think about putting sunscreen on their legs, but that's a common place for people to get sunburn when you're sitting in a wheelchair because it burns the top of your thighs. And also with clothing, make sure you wear cotton or quick drying fabric if you do have a lot of moisture and high heat problems with your body. This will allow the moisture to wick away and the heat to wick away, and will allow the skin to be dry and the temperature to be closer to normal. Next slide. Nutrition. So it's really important to have a balanced diet and to get enough protein. Sometimes the nutrients and protein that you need in your diet increase if you have a wound because your body needs those basic elements to rebuild the skin and tissue. So make sure you consult with your clinic and consult with a dietitian if you're able to get recommendations for how much protein you should be getting in your diet. Next slide. So now let's move on to some of the infections that we talked about. UTIs, like I said, are really common, but sometimes they're not really urinary tract infections. Just because we check a urine study and it looks like there might be bacteria in the urine, it doesn't mean that it's a UTI or an infection. Sometimes bacteria just live in the bladder, and it doesn't mean that there's an actual infection. However, UTIs, if they get really serious, can affect the kidneys, and they can also turn into sepsis. Next slide. What can you do about UTIs? So if you are someone who catheterizes and you get a lot of UTIs, talk to your doctors about whether you should just be using a clean technique or whether you should be using a sterile technique, and whether those catheters should be disposed every time, whether there might be a different type of catheter that might be more beneficial for you. But also really important is hand washing. We know this is important during COVID, but it's important for any type of infection to make sure that you have clean hands before you catheterize yourself. If you're in a place where it's very difficult to find a sink or a place to keep your hands clean, keep some hand sanitizer along with you at all times. Some people who get recurrent UTIs can irrigate their bladder. And what that means is that you put your catheter in, you inject a little bit of saline solution into the bladder, and you let it run back out through the catheter. This can help wash the bladder out, and this is sometimes something that the urologist will recommend. Another thing is to use antibiotics properly. Sometimes people are given antibiotics when they only have bacteria in their bladder and it's not a true infection. And that's really not appropriate. You should only take antibiotics when you really have a true infection. And so sometimes it's important to teach your doctors what a real UTI means. For someone that catheterizes, it's likely for them to have bacteria in their bladder just from catheterizing. So that doesn't mean you have a UTI. A real UTI has symptoms. So you have fevers or chills, abdominal pain, burning when you catheterize, those kinds of symptoms. We don't treat a urine sample just because it shows bacteria. We only consider it a UTI if you have real symptoms. So sometimes you have to tell your doctors that because they aren't taught that, and they should know that. Next slide. Let's talk about pneumonia. So pneumonias are infections in the lungs, and some common symptoms of pneumonia are fevers, chills, coughing. Next slide. What can you do about pneumonia? Talk to your doctors about immunization. So we know that there are shots or immunizations or vaccines for conditions like the flu. The flu is a virus, but some people might be eligible for a pneumonia shot, which does not need to be given every year. So if you think that you're at risk for pneumonia, talk to your doctor about the potential for the vaccine. Some people may be at risk of pneumonia if they have scoliosis, because if you have a lot of curvature of your spine, it can really prevent your lungs from expanding fully. So this can put you at more risk for getting a pneumonia. And if you have that condition, you may need to see a lung doctor or a pulmonologist. And again, good hand hygiene, hand washing and hand sanitizer really help with preventing pneumonia. Next slide. Let's talk about sepsis. We talked about that earlier as being a complication from infection. So this is when infection spreads throughout your whole body. It can come from anywhere, really, but in people with spina bifida, it commonly comes from the bladder and from the skin. And that's when it goes untreated for a long period of time. It starts to spread. Sepsis can be life-threatening, especially in older adults who have weaker immune systems. Next slide. The signs and symptoms of sepsis are fevers and chills, low blood pressure, high breathing rate, high heart rate, confusion, and decreased urine output. So those are some red flag symptoms to look out for if you have an infection, and call your doctor if you think that infection could be spreading, because you want to treat that before it becomes full sepsis. Next slide. What can you do? So again, you want to prevent infections by treating them early, seek care quickly, and treat them with antibiotics when it really is a true infection. Next slide. When are antibiotics appropriate? There's a difference between bacteria and viruses. Bacteria just in your urine does not always mean there's an infection, especially if you're somebody who catheterizes. We would expect there to be bacteria in your urine all the time. Take antibiotics only when you have a bacterial infection. Antibiotics do not work for viruses. So a lot of times people will go to the doctor for things like the common cold, and that is not always treatable with antibiotics, because sometimes things like the common cold, for example, are a virus. And so the antibiotics won't actually work. And it's important not to take antibiotics when they're not necessary, because they can cause problems. They can cause diarrhea, which is really a problem if you've got neurogenic bowel, and antibiotics can start to develop resistance. Your body can develop a resistance to antibiotics if you take them too much. Next slide. Let's talk a little bit about antibiotic resistance, because a lot of people don't understand what that means. So imagine that you have your bladder and it has some bacteria in it, and you take antibiotics, and those antibiotics start to kill off some of the bacteria. The bacteria that are left, and you can see those here in the middle circle, these bacteria are strong. Imagine them as sort of surviving that course of antibiotics. Once you're treated with those antibiotics, those strong bacteria survive, and those are the ones that multiply. And then you end up with more bacteria in your body that are all strong bacteria that are resistant to the antibiotic that you just took. So when antibiotics are not necessary, it's important not to take them so this process doesn't happen. Next slide. So some take-home points about sepsis: always wash your hands, follow good hand hygiene. Sepsis and infections are very serious. Some infections are preventable. Take good care of your bladder and your bowel and your skin, and take antibiotics always the right way. And sometimes that means talking to your doctor about whether they're appropriate or not. Next slide. I want to move on to another topic that commonly affects adults that isn't talked about a lot, and this is lymphedema. Lymphedema is a condition that causes swelling in the body, oftentimes in the legs. And people sometimes don't realize that we have three types of vessels in our body. We have arteries, that take blood to different parts of our bodies. We have veins, which take blood back to our heart, but we also have a third vessel system in our body called the lymphatic system. This lymphatic system is connected to our lymph nodes, and our lymph nodes are what help us clean up infections in our body. It helps clear out the debris and infectious material. And sometimes people can have swelling due to fluid leaking out of that type of lymphatic vessel. Next slide. So lymphedema is different from the types of swelling that you get when you have other problems like, let's say, heart problems. Lymphedema is often tense or hard. We'll call it non-pitting edema because when you press your finger on it, sometimes it is stiff and it doesn't cause a dent. Whereas when you have swelling, oftentimes from your heart, and you push your finger into it, it will leave a dent. Sometimes lymphedema very early on when it's just beginning will have some pitting when you press on it, but oftentimes when you've had it a long time, it won't pit anymore. Lymphedema is actually very common in adults with spina bifida. It affects about 1 in 10 people, and it usually affects both legs, but sometimes can be one leg or the other. And we don't fully understand why it exactly happens, but we do know that it is caused by some damage to the lymphatic system. And this may be from recurrent wounds or infections in the legs because that lymphatic system keeps trying to clean those up and over time becomes full of scar tissue. It can be related to wheelchair use if you have a lot of pressure on your legs in certain areas. Like sometimes people, their wheelchairs are too deep or their cushions are too long and it presses up against the back of their legs and it reduces that circulation in your legs. And we also know that injury to the legs and obesity also increase your risk of lymphedema. Next slide. So what can you do about lymphedema? Well, if you notice that it's developing, seek treatment as early as you can because the sooner you treat it, the better outcome you will have. Lymphedema is very hard to treat when it becomes more progressed. Ask your doctors to think about whether you could have a blood clot because sometimes swelling in your legs can present a similar way to lymphedema. And if there's no blood clots in your legs, lymphedema can be a very effective way to treat it. And a lot of people don't know what lymphedema therapy is. It's actually a type of physical therapy that requires a specially trained physical therapist. And they do a special type of massage of the legs that can allow the swelling and the fluid to be eliminated. So they'll do a massage of the legs and then they'll wrap the legs. And oftentimes you'll notice that you'll have an increased urine output after lymphedema therapy because it's getting that fluid out of your body. And another point is that water pills or diuretics usually don't help lymphedema. They may help the type of edema that you have if you have heart problems, for example, but they aren't that effective for this type of lymphedema. So we don't usually recommend those. Next slide. A lot of people also ask how long do people with spina bifida live? And the good answer to that question is that we really don't know. We do know that we have people who do not have myelomeningocele, who have the other non-myelomeningocele types. We know that we have people who've lived in their 80s and 90s even. But one thing to note is that these are older adults who were born before shunts existed. So these folks generally don't have hydrocephalus and haven't had the complications that you see with people who have had shunts. And so we do know that people with the myelomeningocele subtype do have more complications oftentimes related to their shunt issues. And in many cases, we don't even know why a lot of people with spina bifida pass away. We do know the reasons why they're hospitalized. We talked about those. Those can sometimes be serious and life-threatening. But in a large portion of cases, people from spina bifida pass away from unknown reasons. And that's something that we at the Spina Bifida Association and the CDC are really trying to get a better understanding of with our research. Next slide. So what are some overall take-home points about aging with spina bifida? So first, aging effects can be accelerated. So even though you have spina bifida and your aging may go a little bit faster than people without spina bifida in the way that it impacts your life. So examples of that would be bone loss or problems with your joints like arthritis. A second take-home point is that there are spina bifida specific complications that are related to your spina bifida, and also general complications that are just related to aging and not related to your spina bifida at all. So it's important to have specialists to take care of you who can tell the difference between the two. And you need spina bifida specialists to take care of you, but you also need a good primary care physician to take care of you. And those people can work as a team. And the third important point is take good care of yourself because, like we said, many of the conditions that we talked about are preventable and much more easily preventable if you catch them early. So please take good care of yourself, practice good self-management skills, and you'll be able to prevent a lot of long-term complications as you get older. Next slide. So here's the contact for our clinic. It gives our phone number if you would need to contact us in Pittsburgh, but we also have, a variety of clinics around the country. So if you need information about a clinic in another area, please contact the Spina Bifida Resource Center and we can direct you to specialists in your area. That's all. I thank you so much for your time.
Oh, that was so good, Brad. Thank you very, very, very much. And I hope you are ready for some questions. Here we go.
Sure. Just tell me how much time I have, and I'll answer as many as I can.
I think we're good. We have about 10 minutes to do the questions, but then we have a break from 1 to 1:10, which of course we want people to be able to take their break. But if we need to, we can go over a smidge. So there were a couple of people that mentioned having to be on maintenance antibiotics. Like some of us have to be on maintenance antibiotics and we don't have a choice about it. And it's a big concern. So is there anything you can, and it kind of like follows up on a question too, which is like, how do you know when you're taking too much? Like what is too much?
Yeah, so those are great questions. The old way of practicing was that antibiotics was really the only thing that people could think of as a way to prevent UTIs. And physicians a long time ago used to start people on antibiotics all the time for prevention and just keep you on it forever. But the thought has changed over the years, and research has shown that always isn't that effective. And so we reserve chronic antibiotic use only for very specific cases where we haven't been able to prevent UTIs in other ways. So if you're somebody who thinks you may need to be on chronic antibiotics or you are on chronic antibiotics, talk with a urologist who's really experienced in this area to see if that's really necessary. Because we do find that some people really don't need to be on antibiotics, and there may be other ways like irrigation or other things that we can do to prevent UTIs without you having to be on them forever. And I would say that if you are, how do you know if you're taking too many antibiotics? It's if you start getting infections and you have a lot of resistance to a lot of different types of antibiotics, you start running out of options for treatment. In some cases, we can't prevent that. Some cases we do need to use antibiotics, but if we want to prevent people from becoming resistant to multiple antibiotics as much as possible, sometimes we'll find that someone will develop a UTI and all of the antibiotics that we give by mouth as pills, they're resistant to all of them. So we have to bring the person in either for an injection or we have to admit them to the hospital for IV antibiotics. And we want to try to prevent that from happening so that we don't have to bring you into the hospital for treatment if not necessary.
Thank you. All right, so a different topic now. Is there any evidence suggesting a connection between degenerative disc disease and spina bifida? This person was diagnosed with degenerative disc disease a couple years ago in the same area where her spina bifida lesion is, and the level of the lesion is L4, L5.
So good question. So we do see that some people with spina bifida are born with abnormalities of the bones and discs. So sometimes people are just born with some missing bone in their back, but sometimes there's some abnormalities in the way the vertebrae or the big bones of the back or the discs are shaped. So if you do have some abnormalities that you were born with, it could cause those discs to degenerate earlier than normal. Also, one thing to note is that some people with spina bifida develop osteoporosis or decreased bone density much faster than other people. So sometimes we see osteoporosis developing, in the 40s or 50s, and it's more common to develop osteoporosis below your spina bifida lesion than above.
Okay. And are injections like cortisone to relieve disc pain safe for people who have tethered cords?
So disc problems and tethered cord are two different problems. Tethered cord is where you have your spinal cord sits low and the canal and is sometimes affixed or stuck to the spinal canal. That is sometimes treated surgically. Sometimes there's ways that we need to manage the pain non-surgically if it can't be operated on. You'll get a great lecture here coming up from Dr. Diaz about neurosurgery and tethered cord. Disc problems are different. So discs are the little sort of cushions between the bones of your back. And sometimes people can get tears in their discs, or those discs can degenerate, or they can bulge. And so sometimes steroid injections are done to try to reduce the inflammation around those discs to help treat the pain. So these are different types of problems, and different types of treatments are appropriate for those different problems.
Are you finding an increased incidence of breast cancer? Are you finding more incidences of breast cancer in women with spina bifida? Many women I know locally have experienced breast cancer.
I personally haven't seen any research that shows that breast cancer is higher in women with spina bifida than in the general population, but I do think we're recognizing it more because people with spina bifida are living longer. So they're developing the same problems that other people are getting, and breast cancer is common. Also, I think we're starting to do a better job at getting people with spina bifida the regular screenings that they need. We know that for many, many years, women with spina bifida weren't getting mammograms at the same rate as the general population was. And it was just that their primary care physicians weren't thinking about the fact that they needed screenings like everyone else. And sometimes, hospitals are not as accessible to people that have mobility impairments. So people weren't getting mammograms for that reason. I think because we're doing that more now, we are seeing it more.
Okay. So about leg swelling, I notice my leg swelling goes down after I lay down for the night, and I have to get up and urinate several times in the first 2 hours. So is that something that you've heard of before?
Yeah, leg elevation can help with some types of swelling, sometimes early lymphedema, sometimes even the swelling that people have due to other problems like from their heart. The best way to, if you do have swelling that's responsive to gravity when your legs are elevated, the best way to reduce the swelling is to get your legs higher than your heart. So if you're laying down and you can prop your legs up high enough so that they're above your heart level, you'll have a better effect in reducing the swelling. And the way that you can do that in your wheelchair, if you have a power wheelchair with power seat functions, is to use your tilt function and to elevate your legs at the same time. So that's a way for some people to do it in their wheelchair as well without having to transfer out.
Okay. What's the best way to treat a wound on the butt that's caused by moisture?
So I always say, treat the underlying problem first. So the best problem, if the wound is from moisture, we got to treat the moisture. We got to remove the reason why the wound is happening. But we also have to think about the other causes, because sometimes it's not just moisture itself. Sometimes there can be pressure and shear and temperature and all of the things we talked about also contributing. So we have to treat those as well. And then I would say also see a wound specialist, because the treatment for wounds differs depending on how deep the wound is, whether it's draining, where it's located, what size it is. There's all different types of treatment, and it can get complicated. But I think the take-home point is you need to remove the causes of the wound in addition to treating the wound itself. That's really what's important for healing.
So along those lines, is it normal for someone to take Keflex 3 times a day for a pressure sore?
The antibiotic Keflex is used for skin infections or cellulitis. So that may sometimes be used if there's a local infection in the skin. We wouldn't necessarily use Keflex for all wounds.
So now talking about bone density, should we get bone density checked?
Yes, so that's something you can talk to your primary care physician about. We don't have great guidelines about osteoporosis and spina bifida. In fact, there's not a lot of research in that area. We will be happy to hear that a new section of the healthcare guidelines will be coming out that will address bone density and osteoporosis. So that will be our newest section. So watch for that. But for now, in terms of when you should get your bone density checked and at what age, I would talk to your primary care physician. It's also really important to talk about where when you think about checking bone density. We oftentimes recommend that the leg, the femur, or the area of the bone around the knee be an area that be included in the bone density test, because that's a little bit more accurate in people with spinal cord injury or spina bifida. Not all places can do the bone density like that. So not only ask about when and what age for the test, but also ask if your doctor can recommend specifically the parts of the body for the test to be done.
I've been diagnosed with osteoporosis and osteoarthritis at the age of 43. Is there a correlation between that and spina bifida?
I think osteoporosis and osteoarthritis all happen with aging. And so due to the fact that we have people with spina bifida who are aging, they're naturally going to get those conditions as well. It's just that people with spina bifida might get those a little bit earlier than other people because there are other factors involved. There might be medications that predispose you to osteoporosis that some people take. You may have lower weight bearing, because you don't put a lot of weight on your lower limbs that could predispose you to osteoporosis, for example, or you might be predisposed to osteoarthritis because of issues in your spine, for example. So I would look at it as normal aging. It's just something that's happening maybe faster and a little bit earlier just because you have spina bifida.
Okay. I'm dealing with bladder cancer for the 3rd time since I was 50. I am now 67 years old. Is that common?
Bladder cancer is somewhat common in the spina bifida population. I'm sorry to hear that you're dealing with that, especially recurrence. But we do see that in folks, sometimes people that have indwelling catheters, that have been in the bladder permanently for a long period of time, or some people that have certain types of surgeries around their bladder may be at risk. So if you're somebody that has any problems with your bladder at all, really, make sure you follow with a urologist, because they may do a test called a cystoscopy, which is a scope. And that is a way that they can see the bladder tissue and catch those problems early, or be able to tell when they need to be treated.
There are a few questions that will probably be addressed later this afternoon in the physical activity session. It was about joints and if there are exercises or anything else that one can do to keep the joints strong and active, specifically the hip, knee, and ankle. So Dr. Dicianno, is that something that you think we're going to, that you would like to address now, or maybe save for later?
I'll leave it to those folks to address in detail, but what I'll say is, everyone should have a physical activity program. We have recommendations about how often and how much people should exercise, and we'll go over those later. But I think the take-home point is that, different types of exercise is also important. So resistance, where you have some sort of exercise program that involves weights or machines that have resistance, stretching, and cardiovascular. It's important that your exercise program have all three, because sometimes you can miss out on the heart benefits from the cardiovascular, the range of motion benefits from the stretching, and the strength, the preservation of your strength, and the density of your bones that can benefit from the resistance training.
Okay. All right, so it's 1:02, and so we are technically on break. So if you have to go, please go ahead. But Dr. Dicianno, if you have a couple more minutes, I think we're almost done with some of these questions.
Sure, we'll go through the last couple questions.
Okay, thank you. So do you have any thoughts on nightly leg pain or spasticity that can get progressively worse with age? Despite not having any feeling in my lower legs, there are nightly spasms, pain, toe cramps every single night.
Yeah, if it's true spasticity, and what we mean by spasticity is tightness in the muscles, and oftentimes this can be associated with jumping or involuntary movements in the legs, that can be coming from your spinal cord. So it would be important to see your doctor to see what the cause of that is. So some common things that cause spasticity are tethered cord, a syrinx in your back, those kinds of problems. So if those are present, those may require another type of treatment. But for people that aren't surgical candidates, that don't need that type of treatment for spasticity, there are ways to treat it with medications. There are medications that treat the spasticity itself. There are oral medications and also injections. There are also medications that help with just nerve type pain in general that you may be eligible for. So there are a variety of different types of options out there if you have that much pain. So I would say see a neurosurgeon or see a physiatrist to start to help identify the problem and the treatments that might be available for you.
So we've talked about physical decline, but is there any data on memory or mental decline?
That's a great question. We've had some people ask recently whether there's an association between dementia or Alzheimer's and spina bifida, and we don't have a lot of great research on that. We do know that people who have who've had hydrocephalus and shunts experience some executive function problems, and sometimes you can develop more problems over time if you've had recurrent issues with your shunt. So you needed like multiple shunt revisions, but we're still kind of at the early stages of understanding long-term memory impairments in people with spina bifida. But I think we'll know more as time goes on, as people age and get up into their 70s and 80s and 90s. But we haven't, seen that as much yet for the folks who have shunts.
Cool. And there's another data question. Is there an average, rough estimate or anything at all on the life expectancy of someone with myelomeningocele?
Yeah, like I said, we don't have exact numbers. We do know that people with non-myelomeningocele live into their 80s or even to their 90s. There are, a sufficient number of people out there for us to be able to say that. We don't know that's the case necessarily for people with myelomeningocele who have had shunts, because there are more complications for people that have had shunts. But, again, that's something I think we'll learn more of as we follow larger groups of people, like in our registry.
Okay, thank you. All right, and then one last one. Do you only have myelomeningocele if you have a shunt? I have myelomeningocele, but no shunt.
Another good question. So Most people who have myelomeningocele have hydrocephalus and require a shunt, but not everybody. There is a subset of people with myelomeningocele who never need a shunt. And shunting is also pretty rare in people without myelomeningocele. So of all the spina bifida subtypes, people with myelomeningocele are much more likely to need shunts than people with other types of spina bifida. So it's possible that you could have a non-myelomeningocele type and need a shunt, or have myelomeningocele and not need a shunt, but it's just less common.
So I was wrong. Actually, there's a couple more questions if you don't mind.
Sure.
Is there a need to have a non-functioning bladder due to urostomy checked regularly?
That is a complicated question because it may depend a little bit on your medical history and why that bladder is non-functioning. I think it would be important to follow with a urologist in that specific case to answer that question.
Great. And then here's another one, but I think that actually we will probably address this later on this afternoon in the women's health session. So we have a whole 3 minutes for break. So thank you so much, Dr. Dicianno. This is so great. If anybody has more questions, please just keep sending them over and I'll make sure that we save them and then send anything over for Dr. Dicianno to respond to later on.
Thank you. Yeah, these are all great questions. They show that people are really thinking about their health and concerned and wanting to do the best things for themselves. And so we all need to be our own self-advocates, especially those of us that, don't have access to care, in different areas. So if there's anything that we can do to plug you into better care or answer your questions, please feel free to reach out. We're so happy that you joined us today.
Yeah, thank you. We are so happy that you joined us today, Dr. Dicianno. Thank you so much. We hope you
all.
Have a good rest of the day.
Bye-bye.
All right, everybody. So just hang in there, I guess, for a few more minutes. This is the time that you can go and do whatever you want for a couple more minutes. You will probably hear us speaking again soon. We're going to have, let's see, what comes after this? Oh, pretty soon, we're going to have the keynote panel of adults with spina bifida. So please just hang in there for that. And we will be back shortly.
It's a common summer scene. Children playing in the water, splashing each other, or going down a water slide. But for some kids, like Sam, water is an obstacle.
We typically avoid water parks because we know there's the ladder scaffold involved. You have to get up to the slide. And also the rides in the water parks typically just aren't good for someone without balance. So that's just in general water parks a challenge.
And being in a power wheelchair makes it even more difficult. These wheelchairs run on electricity, and when water comes in contact with them, the results can be shocking. So how do you build a water park that all kids can enjoy? That's the question Gordon Hartman had. He runs the world's first accessible theme park, Morgan's Wonderland in San Antonio.
We had to come up with a wheelchair that would allow for it to get wet and still be able to move about. through the use of someone's ability to use a joystick.
That's when he discovered the work of Dr. Rory Cooper at the University of Pittsburgh School of Health and Rehabilitation Sciences. Dr. Cooper is world-renowned for numerous patents and inventions when it comes to wheelchair technology. He's dedicated his life to improving assistive devices for people with disabilities.
I found Dr. Cooper from the first conversation we had on the phone as a person who really wanted to work hard at ensuring that this idea that we had of developing this chair, which would truly be revolutionary.
Gordon and I have the same vision. That's a world where everybody can participate together so that people with and without disabilities are on the same playing field. The idea is that, hey, an air motor with air tanks, if it's feasible, may provide with a much lighter power chair, much more environmentally friendly, that doesn't need to have the batteries replaced.
And from that idea, a new chair, short for pneumatic chair, was born.
The new chair is powered strictly by compressed air. There's no batteries, so that makes it waterproof. We can recharge it in as little as 10 minutes. Unlike current battery wheelchairs that could take up to 8 hours, it could revolutionize the wheelchair industry.
Brandon Davler, a current graduate student at Pitt School of Health and Rehabilitation Sciences, is a researcher studying under Rory Cooper. Their team works out of the Human Engineering Research Laboratories, where they modeled and built the new chair. The chair that makes a challenging trip to the water park, well, fun.
I like to have the freedom to run around.
It was rewarding to see just how he lit up and the enjoyment that he got out of going through the sprinklers and the water.
He wants to be independent. Quite frankly, we let him go for 30 minutes by himself, and that's what he wants.
And Rory thinks children without disabilities who witness this independence will be influenced too.
That's the kind of experiences you want kids to have so that when they grow up, they don't have those biases and they can say, hey, I've seen people with disabilities do it just like I have.
The positive influence of the new chair doesn't stop there.
The granting agencies and the clinical work sort of force you to think about a lot of more in the medical aspects of life. And it was great to see how much demand and energy there was for just having fun.
I've already seen how this chair has made a difference in the lives of those with special needs. The reason we are where we are today is because of Pitt, the commitment of Dr. Rory Cooper, all of his close staff and everyone involved who have made the dream of this chair possible. And I think in many ways we're just beginning.
I hope it expands through water parks. I mean, we've been contacted by the National Park Service and the state parks for putting it at wave pools, beaches. I also think it's got a lot of potential for long-term care facilities and nursing homes, big box stores. We had grocery stores and things contact us.
Gives us hope that one day we won't have to worry about any type of barriers in our world.
Thank you for joining us. Please welcome our keynote panel with Julie Yindra, Matt Davis, Brian Gutierrez, and Kathy Price-Toby to talk about living through middle age and beyond.
Greetings, everyone. My name is Julie Yindra, and I'm looking at the screen and I see a lot of familiar faces. Hey, y'all, how you doing? It's good to see everybody. Okay, so as we are gathering and getting situated and figuring out which one of these links we're supposed to be in, I'm just gonna start by saying to all of those of you who don't know me, which I don't think is very many, my name is Julie Yindra and I am 58 and I have spina bifida. I currently live in New York on Long Island and work in higher education administration. I want to give the rest of my panel a chance to introduce themselves briefly as well, starting with Brian. Brian, how you doing?
Hi, Julie. Good afternoon in your area. Good morning if you're in the West Coast. Good afternoon if you're in the East Coast. Once again, my name is Brian Gutierrez, and I am an adult living with spina bifida, 30 years of age. I am a current graduate student majoring in rehabilitation counseling from Cal State Los Angeles, and I reside in Los Angeles.
Fantastic. Matt.
Hello from the Midwest. Hello from Kentucky. I'm Matt Davis. I see a lot of, like Julie said, a lot of familiar names and faces. I'm currently the assistant director of the Student Accessibility Resource Center. I do similar what Julie does at Western Kentucky University. Also an adjunct faculty member, and I do involved in a lot of adaptive sports. It's nice to be here.
Matt's being modest when he says he's involved in adaptive sports. We'll hear more about that later on. Kathy Price-Toby.
Hi. Hi, everyone. I just wanted to say I'm from Reno, Nevada. I'm also an adult living with spina bifida. And I've been here in Reno for 22 years. And I work as an investigations coordinator, for the Silver State Fair Housing Council. And basically what that means is we assist people who feel like they're being discriminated in their housing. And disability is one of those very big things that we work with.
Great, fantastic. So we want to just sort of guide this conversation with a couple of very broad, basic questions, and then we'll zero in on some key points. But the first thing I want to say is that, each one of us is going to talk a little bit about things from our own perspective based on our own personal experiences. None of us have all the answers, right? There's no right way or wrong way to go about this. There's no right answer and wrong answer. Everybody's life trajectory is different. So we're not here to tell you how you need to live your life. We're here to tell you about how we live ours and maybe give you some little kernels of advice along the way. So my first question to each of the panelists is, at this stage in your life, what aspects of your life are going as you had expected or planned, and what aspects are not? Brian, let's start with you.
Thanks, Julie, for the question. Looking back at this question, I was pretty much starting to that, actually. I think one of the aspects that's going in my life really, really well, as expected, is I'm going to school. I am completing a Master of Science degree in rehabilitation counseling. But to get there, it was very rocky. My parents did not expect me to pursue a master's degree. They had the expectation of myself just completing community college. But I always wanted to aim higher and really transfer from a community college to a university. And I got my bachelor's in rehabilitation services. And now here I am completing a Master of Science in rehabilitation counseling. And just living myself independently as much as I can, occupationally doing things on my own, putting on my shoes, leg braces, and even cooking, which I myself have limited cooking, but I'm still learning as I go. I think one of the aspects that it's not going so well is driving. I have yet to learn how to drive. My parents did not want me to learn how to drive. They were terrified. They were scared that something bad might happen to me because of spina bifida. But I am still fighting for that, and I'm hoping to be able to drive soon as possible. But yes, my parents had a different expectation that no, I don't want you to drive. You're not safe. So, but I'm still fighting for that independence. And yes, so I think that's one of the aspects that's not going well so for me at this point in life.
Thanks, Brian. Kathy, how about you? What's going as you would have planned or expected, and what's not?
Well, I'm sorry. One of the things that is going really well for me is that I'm in a marriage that I've been in for 19 years, if you can believe that. I still can't believe it sometimes myself, which is kind of funny, but that's okay. And then also, I have a great job. I mentioned my job earlier, and the one really nice thing about this job is through this pandemic, I have been able to work every day. We have not had to close our doors. There's only a few of us. We only have 7 employees statewide. And so it's been really easy to just stay in my office. I wear a mask if somebody comes in. Otherwise, we're all on our own, and it's very, very safe. So I really have felt like that's been a really, really good opportunity for us to continue making differences in the lives of the folks that we assist. And then also my body, that's the thing that I didn't expect. I did not expect my body to fail on me. And that's exactly what it's done. It's, I used to be very active. I used to dance. When I was a kid, I played jump rope and hopscotch and all those things. Even, though I had spina bifida, I was completely what I considered myself to be able-bodied. And then at about 45, things just started going down, and like, okay, well, some of the stuff is spina bifida related, but most of it is just I was getting old. And I didn't really appreciate that very much. But, that's how things happen. And so, you learn to adapt. And that's the key, just learning to adapt to the things that you can now do, and the things that you can't do, get help, or, do what you need to do, but keep going. And I think that's pretty much how life is going to continue to be for me now. And that's okay.
Yep, absolutely. Matt, what about you?
That's a lot to live up to, some of these responses. These are pretty good. Some of the things that it's interesting for me, how our situations are similar but different. Of course, Julie and I, it seems like she's a sister from another mother sometimes from some of the situations that she talks about. But with Brian's situation, mine was a little bit different, because one of the things I think that surprised me that went so well is looking back at my teenage self and wish I could talk to my teenage self now, how well things have turned out for me that I didn't expect it to when I was that age. So I thought I was going to be at a different path, didn't even know. I was like, I probably won't even be alive at 54 years old. So just party up and have a good time. And so I think that's one of the things that surprised me was how I still have goals. Everybody should have goals that they want to achieve in life, no matter what your age you are, something to look forward to. And so I think that that's one of the things that sort of surprised me and that it went well. Some of the things that didn't go so well, I think is just those stumblings that I had when I was in my early 20s, like the dark cycle that I was in and didn't think I was going to get out of, and was able to get out of that. And, it's just having that experience really kind of shaped who I am today, though. Some of those things that happened to me at an early age. And so, and some of why I went into the field that I'm in. And so I think that that's some of the things that, as far as looking back on it, that didn't go so well. I wanted to be a full-time professional athlete. Obviously that didn't work out. So I had to get a real job. So I think that those are some of the, but looking back on it and where I am today, like I said, I have things I want to achieve. But like Julie, it's been this kind of road. It's been a long, windy road, and the road been setbacks, but persistence, I think, is the key to getting where you want to be.
I think, Matt, you're absolutely right. I think persistence is the key, because if there is one word that describes sort of the course of my life, or 2 words, it's been screwing up and then recovering, right?
Right.
All my life, screwing up and then recovering. And I, like Matt, there's kind of an inside joke among some of us in the spina bifida community that are in my age group. And that is, the good news is that we're growing old, and the bad news is that we're growing old. In both things are true. I think that in terms of what's going as expected in my life is, I always expected to be working, and I am, and to be able to be self-sufficient, and I am. A couple of things I didn't expect. my level of spina bifida and the level of at least physical disability early in life was fairly minimal. I was ambulatory and freely ambulatory for the better part of my life. And in my 40s and 50s have, obviously that has changed, and I have spent, more and more time sitting and less time standing. And now at 58, I am transitioning to totally being a chair user. And so when I was in my 20s and 30s, that I didn't expect. The other thing I didn't expect, which is part of the growing old, is like Kathy said, some of the stuff that's happening to us and to our bodies has to do with spina bifida, and some of it doesn't. In 2013, I got breast cancer and had surgery and radiation and took medication, and it went away. And then in 2016, it came back with a vengeance again and became metastatic. And going through that, both mentally, emotionally, and physically, I think has sort of expedited some of the mobility challenges that I already had. So you can plan all you want, but stuff's going to happen, right? Stuff's going to happen that's going to throw a wrench. And I think that's why this notion of grit and resilience is really important. Whatever life throws at me, I'm going to handle it. And that's been an attitude that has been instilled in me from early on from my parents. So my next question is one that is a frequent topic of conversation among older adults that have aged, long since aged out of the pediatric clinical care model, and ask my panelists to talk a little bit about how they're managing their healthcare needs, and if they have any tips and strategies for folks that are listening in terms of managing all of that. Starting, Brian, how about you? How are you managing your healthcare needs and balancing that with everything else in life?
Thanks, Julie, for the question. You did mention that what you're alluding to is that we should prepare for the unexpected. I myself went through a pressure of sore when I was about 22 years of age, and that was unexpected for me. And I just gone through a bladder procedure where I was diagnosed with bladder tumors, and I am tumor free. So managing the healthcare needs, I think I have to make sure that my appointments are on track. My list of medications are also on track, and I get a list of those medications that I'm currently taking and how much, which is very, very important to our bodies, right, for people living with spina bifida. And I think just also just getting a portfolio. I myself have a medical portfolio which I keep in track of all the appointments, the doctor's notes, the list of medications as I briefly mentioned, and the future appointments, and also any diagnoses that that I have in these case notes of my doctors. So that's definitely one of the tips that I'm using. But also just making sure that my health is stabilized and making sure that that everything's up to date, my medications, my appointments, and so on.
Great, great. Kathy, what about you? How are you juggling all of this?
Well, I've been very fortunate. I don't have any surgeries coming up anytime in the near future, fortunately. So I don't have to worry about that right now. I've been fairly healthy in that regard, but I do have to have medical supplies. And that's really, really important to probably every single one of us in some form or fashion. And one of the things that I learned recently is that you need to keep really close eye on your primary care doctor if that's the person who's writing the prescription for your medical supplies, because a lot of these providers, supply providers, have to have a doctor's prescription in order for your insurance to cover, what you're needing, and so that you can reorder it as you need it. And my primary care doc left his medical group, And I thought that I had all my bases covered. He'd, written all my new prescriptions and everything. I forgot about my medical supply prescription. I didn't realize that it was going to be expiring so soon. And he left in December, and I called my insurance and they said, yeah, sure, he's going to be covered. So no problem. So I asked him to send in an order, which he did, no problem. But then 2 months later, after fighting with this insurance or with the medical supply provider, because they couldn't find an order, they said, or my insurance company said that he's no longer covered. So I was down to one item of supplies, and that could be very dangerous and very embarrassing. And as it turns out, be aware of a local nonprofit that might be able to help you, because I literally ran out of supplies and had nothing coming my way. And I didn't know what to do because I needed it right that minute. And fortunately, I was able to find a local nonprofit that does this. They have medical equipment, medical supplies, everything under the sun to help anybody who needs it. And even though I have insurance and I have a job and everything, they usually help people who don't. They said, oh, I understand you're in an emergency situation. Here's some supplies. If you would just give us a donation, that would be really nice. And I did. And I mean, that makes total sense. And I had no problem with it. But the key here, the main point is, be sure that your prescription for your medical supplies and your meds as well is up to date with your primary care all the time. And if they're going to change, if they tell you that they're changing, jobs and moving to a different place, then you need to make sure that they've written even including your medical supply prescription, because that was a big boo-boo on my part. I should have had him do that too.
Yeah. Yep. Matt, what about you? You're on mute there, buddy.
I saw a meme on social media that said one of the most popular phrases of 2020 and 2021 was "you're on mute." But as far as my medical needs, I learned a couple of things. One, and this has been fairly recent, so you're never too old to learn, as my mother would say. So when the pandemic hit a year ago, some of the supplies that I need, it was really a big concern for me, is because of this, the demand and the scrounging around all over the nation for PPE. Some of the stuff that I need was I was going to be able to get some of my supplies. So what I did was I thought right away, my medical supplies that I get from my home health care, I need to get more than I usually do. In case something happens, I need to prepare that maybe we're in lockdown for a couple of months. This is a year ago. And so I thought in my mind, I need to make sure that I have at least 2 months supply instead of 1 month. And so that was part of that whole taking care of my own medical needs, that I needed to make sure that I didn't run out of those and I'm not in panic mode because I'm 2 days away from running out of whatever I need. So, and the other thing that I learned recently, my primary care doctor had the nerve to retire after about 50 years in practice. I mean, so it was that transition to a new doctor. And in my new doctor, I asked him the first time I met with him, which is important to ask, if you have a new primary care doctor, what do you know about spina bifida? Do you know anything about spina bifida? And he goes, you know what, I'm really not familiar with it. I had, people in the past that I've worked with patients with spina bifida. So what I did, I went on the Spina Bifida of Kentucky and the National Spina Bifida Association website, got some information, put a whole packet together and dropped it off to my doctor's office. So he would have that for my file. So he would be more familiar about some of the symptoms that I could be experiencing that may not be related to it could be related to the spina bifida. So I think that was important for me, for peace of mind, to be proactive, to give my doctor that information about spina bifida, so they would have those tools in case something come up that could be spina bifida related. So as far as taking care of my own medical needs, it's come full circle with my family. My mom, when I was a teenager, said, "You're an adult, you're going to start doing your own appointments, you're going to keep up with this." And now my mom says, "Can I go with you to your appointments? When is your appointments? I'm going to go with you." So it's kind of interesting how it's gone full circle, but it helped me get those tools that I learned over the past year, what I needed to do to be proactive.
Yeah, and I'm going to be the last person to answer this question, and I'm going to be very honest with the folks in this room and say that in recent years I have failed in this respect. When I got cancer, really the only thing I had the time and the energy to deal with was cancer. So I've been on top of that in a very big way. And I see my oncologist once a month, but I haven't seen a urologist in a couple of years, and I haven't had a physical in a couple of years, and I, haven't seen an ortho. I need a new brace. I let lots of other stuff slide because I was like, look, I live alone and I live in New York and I have a full-time job and I have cancer, and that's the only thing I can pay attention to right now. Right. And that, looking back, was probably it was a mistake. And I am in the process of rectifying that. Things are looking up and looking good on the cancer front. And so it's time for me to go see a urologist and go to an orthopedist and get a script for this new brace and get that thing moving, because I just sort of and then the pandemic just made that even worse. Right. Now I can't go to the doctor because I can't leave the apartment, right? I'm quarantining. So I've really had to make a conscious effort to say, I'm going to get this team of people back together again. One question I had for each of the panelists in this vein before we move on to the next thing is just, how difficult has it been for you to get your various doctors to talk to each other, or do they even talk to each other? And what's that battle been like? Brian, what about you?
Yeah, we talked about the pandemic, and it was earlier on the pandemic, it was very difficult for me to talk with my doctors, especially to get a hold of them. During that time in the pandemic, I was having various UTIs. It's very common for people with spina bifida. And it was very, very difficult for me to get a hold of those guys. Do I need to go to the ER? Do I need more antibiotics? What's this, what's that, right? So I didn't have no guidance or direction whatsoever until like 5 weeks or in a month afterwards. That's when my UTI got worse and I had to go to the ER and to get treatment. I think, looking back at it, my doctors don't really communicate with each other whatsoever, unless if it's probably doing a procedure or surgery. That's when I get to talk with not just my doctor or urologist, but also the anesthesiologist, surgery, care nurse, excuse me, and other medical professionals. But early on in the pandemic, it was very difficult. And of course, Matt, you talked about supplies. It was very difficult for me to get access to these supplies, because I was in that zone where my supplies were running out. And I had to call my provider, Biome Healthcare, let them know that I am running out of supplies, that I need extra more, at least for the next 5 months, because as we mentioned, prepare for the unexpected, right?
Right.
We never knew how that pandemic would last or what impact it would have on us, which it all had a great impact on each and every one of us. Different, but it was a lot of chaotic. But it was very difficult. It was very difficult. Thankfully, it's more settled for me. It's not that level where I expect it to be yet, but sometimes my appointments have to be scheduled for a phone call. I need to go see a doctor in person, which I prefer, especially when you're going through a UTI. So
right.
It's been very difficult.
Right. Kathy, what about you? Do your doctors speak to each other? Do they collaborate?
Heck no. That's the biggest problem. They just don't. Fortunately, I've not really needed them to, but here in Reno, they just don't do that. I had an orthopedic issue back in 2014, and I tried to get them, to talk to anybody and, kind of learn more about what was going on. And all the doctors here in town refused. I ended up having to go to Carson City to work with a doctor who actually is the head of arthroplasty, in San Francisco, who works in Carson City periodically. Well, Carson City is about a half an hour away from here, so it's not that bad. but it was just really frustrating that I couldn't find a local doctor to even want to take care of my orthopedic issues, which I thought was really wrong. But as far as talking to one another, not at all. I only have an orthopedic and the urologist, and then of course the primary care, and nobody talks to anybody.
What about you, Matt?
One of the things that I've learned is that, I'll answer your question. My doctors probably don't communicate with each other unless there's some kind of, if something emergency comes up. So one of the things that I've learned, and I think it's genetic because I get this from my mother, she does the same thing, is whenever I go to my other doctors, I get copies of the records. I don't rely on them to send it to someone else. I get copies of the records and I drop them off at my primary care doctor's office. So all of my records from the doctor's office are in one spot. So if my primary needs information about GI stuff or urology or, then those records should be in one place. And I've learned that that's probably the most efficient way, because to rely oftentimes on doctor's office, some are better than others. We'll fax that to them. 2 weeks later, well, did that happen? No, we didn't get it. So it's back to that self-advocacy. I want a copy of what happened today. I want a copy of the records that I have for my own use, and then I drop them off to my primary care doctor so it'll be in one spot.
Excellent idea. Excellent idea. One of the reasons I wanted to ask this question was when I got cancer, I was at the oncologist's office one day, and I happened to say to the office manager who's behind the desk in the doctor's office, I said, was the doctor able to, or will the doctor be talking to my other physicians? And she said, no, probably not. And I said, why not? And she said, because there's no billing code for that.
Mm-hmm.
So folks, we as a group need to continue to push and advocate for a healthcare system that promotes and provides opportunity for collaborative care, for doctors to be encouraged and incentivized to communicate with one another in providing our care. It says it right there. There's no billing code for that. Well, there needs to be a billing code for that. Yeah. Right? So my last question I want to ask before we open it up to everybody is, as you look to the future, what are you most looking forward to and what are you most worried about? And this time, Matt always tells me that I've been picking on Brian all day because I go with him first. So this time I'm going to go first with Matt.
Wait, I'm not prepared. What am I most looking forward to, and what are my fears about getting older in the future? Yeah. I think that one of the things that I'm looking more forward to, and I think a lot of us are, getting to be able to do some of the things that I was able to do prior to a year ago. And one of the concerns that I have, I made this comment to a friend of mine, and some of you who know me know that I do adaptive sports. But one of the comments that I made to another friend of mine is, I'm not going to let the pandemic retire me. So that incentivized me to keep active during the pandemic, to have something to look forward to. So I'm looking forward to, as Julie is, eventually being able to retire here in not too distant future, and what that's going to look like. And so, and that's something to think about when we get to be our age. And one of the most fearful thing is, and a lot of us have this concern, I think, with spina bifida is, and Julie, you had brought this up before, is having those supports in place to make sure that my family is not responsible for taking care of me when I get older. And so that's something that has always been, in the past 5 years or so, been a goal of mine, to make sure that I have as much as I can in place to make sure that if I'm not able to take care of myself, that they have those supports that are in place to help take care of that. And so I think that's one of the fearful things is, one, not being able to take care of myself as I get older, but two, not having that responsibility put on my family.
Yeah, absolutely. Kathy, what about you?
Well, I'm really looking forward to retirement, and in a little over a year, I'm actually going to be able to do it. Hopefully, fingers crossed. But one of the things I want to keep working at my current job, but I want to do it part time. You know, I don't want to work full time. I want to go out and do what I used to do a lot, and that is volunteer work. I love working in the community and doing things to help other people. And, you know, just, you know, one-on-one with folks, trying to help people. You know, I have this lovely little lady that I take to the grocery store about, probably once every couple of months, because there's a certain grocery store up by me that she loves to go to. But I haven't been able to do it during the pandemic. So I'm looking forward to being able to help her. She's 90 years old. She needs somebody to take her places. She doesn't drive. So that's one of the things that I'm looking forward to, is being able to get back to that and retire, have more time to do more things. But one of my biggest worries is, once again, my medical supplies. You know, once you retire and you go on Medicare, then you have to figure out, okay, do I go with an Advantage plan, or do I have to get a supplement? Who's going to cover my medical supplies? Do I have to get the pharmacy thing? Oh, yes, you do, or you'll get penalized. Excuse me. So those are the kind of things that really, really worry me for the future. And I've been doing some investigation in it. So I'm hoping that by the time I retire, I'm going to have it all figured out. Right now, I don't have to do that because I am covered with insurance at work. But once that goes away, and even if I go part-time with my job, I won't have insurance anymore. So I will have to be sure that I'm taking care of that. And like everyone else has said, I definitely don't feel like I want to even attempt to rely on my family, because they have their own lives. They have kids. They have, you know, lots of responsibilities, and they don't need me added to that pile of experience. So that's why I want to, you know, be able to take care of myself, as, you know, forever until I'm gone.
Great. All right, Brian, you're up. What are you looking forward to, and what are you worried about?
Thanks, Julie, for the question. I think what I'm looking forward to as a millennial myself, I just getting my life started. Looking forward to employment. Looking for a full-time job at a community college after school. Definitely setting up on my own retirement plan savings, which I gotta start doing that ahead of time, which is very, very important. Us millennials don't think about those things. We think about career goals, we think about employment goals or education goals. Those goals are nice, but we don't think about what's ahead of us after 30 years or 40 years and so on. So we think about other things. I think what I worry about the most is really having to look for other specialists if my insurance does changes as I get older. Currently, I am very satisfied with my urologist at UCLA, who has been taking care under his care for more than 15 years. And so far, I have great experiences there. And we, even as Kathy was saying, medical supplies, I feel like those are running out. I have Medicaid, and Medicaid does not cover fully for the supplies because of the pandemic. So I had to stop advocating for myself, keep on calling 24/7 and fight for that. It's very, very important. So I think, you know, long-term, those needs are going to change. And that's what I fear about the most going forward.
Yeah, yeah. You know, for me, I am looking forward to retiring. I'm looking forward to more theater, more kayaking, more hand cycling, more time with family. And I'm planning for that, because when I think about, you know, retiring, it's not just a light switch of I'm working, then I'm not working. It's, what do I want that to look like? Where do I want to be? Well, I want to be near my family. So I'm going to leave New York and go to another state when I retire. Where am I going to live? Am I, you know, and one of the things I'm thinking about is, when I choose where I want to live in retirement, I'm cognizant of the fact that my needs will likely change rapidly over time as I age. So do I want to be in a community where there's some sort of graduated assisted living possibilities, right? So I don't want to just go and like say, I'm going to buy a condo. I want to buy a condo in a complex where maybe there is the capability of moving to more assistance as I get older and as I need it. But I'm also, you know, I keep thinking about my father's mother, my grandmother. When she retired at 65, she came home, put her feet up on the easy chair, turned on the television and watched The Price is Right and said, I'm old, I'm done. That's not going to be me. And every time we said, hey, let's go on a vacation, no, I'm too old. I'm not going to do that. I'm planning, what do I want to work at when I retire? Do I want to do some tutoring or some private, you know, college consulting, or what, you know, nonprofit organizations other than SBA, which obviously I've been involved in for a long time. You know, what do I want to do with my time? I'm not thinking of retirement as I'm going to go sit. I'm thinking of retirement as there's going to be more time for all the stuff I really enjoy doing. You know, but I have to plan it carefully because financially, we're all worried about finances. We're all worried about, because I didn't start saving early enough. When my parents told me when I was in my 20s to start putting money into a retirement account, I didn't listen because I was stupid. So I didn't start until much later. So I'm sitting here with a pen and a calculator, which for a lot of people with spina bifida is not an easy thing, because a lot of us have difficulty with math. And I'm thinking about what does my retirement disbursement look like? How much money am I going to be able to get monthly from my 403B at the university? How much money am I going to get from Social Security or Social Security disability? What's my insurance going to look like? And I have to figure out, you know, what's my standard, what are going to be my means? Because like everybody else on the panel, I want to live, even in retirement, I want to live according to my own means. I don't ever want my brother to think that he has to financially look after me, you know? So I'm looking at all that and I'm getting professional advice. So the advice I have for everybody is talk to a lawyer, talk to an accountant, talk to people who know this stuff inside and out, where you can have money, where you shouldn't have money, how you should shelter your money. Talk to professionals and take their advice and plan. That is the best advice I can give. So we now have a few more minutes left for folks to ask questions. Juanita, you want to sort of field anything that you're seeing in the chat that looks like a question we should address?
I do. So just the general theme about retirement, but let me get to something more specific first. Well, actually, no, let's go into retirement. And just like what you were talking about, like financial planning. What will our life look like for us with spina bifida as we get older and as our families get older? At some point, our families won't be able to help us. Then what do we do? Just like you were saying, what's your advice for preparing for retirement or going on disability, preparing financially so that you still have health insurance, accessible housing, and much reduced income because you're not working? And you actually just...
So, yeah. So the first thing is, when I wanted to find an attorney to talk to about financial planning, I asked an attorney that my family knew not to talk to me about that, but to refer me to an attorney they knew that specialized in this kind of financial planning. You know, I know that everybody's got a unique situation, but really not every attorney and not every accountant and not every tax expert is really good at the unique circumstances of the disability community. So I'm gonna give a plug to Juanita here from SBA and say that SBA can help you identify, and the National Association and local chapters can help you identify folks in those professional fields who might be particularly knowledgeable about all of the twists and turns with regard to disability and benefits and all that kind of thing. Don't just go to, a generic attorney or a generic accountant. Look for someone in those professions who specializes in our population.
That's absolutely right. And later on this afternoon, one of the presenters will be from Disability Rights Pennsylvania. And there are disability rights organizations all around the country. And those are probably good places to start in terms of finding, like Julie said, someone who is the right person for your needs versus just the person on the billboard, which you probably should not call.
One of the slides that was up in between sessions, or maybe at the beginning of the day, was Centers for Independent Living. There are tons of Centers for Independent Living all around the country, and they are a resource center for folks with disabilities. And they should be and could be consulted and say, in my local community, can you recommend some attorneys, or can you recommend some financial advisors that are, so ask the Center for Independent Living nearest you who to go to. When I was thinking about, I'm moving to Massachusetts, and I wanted to get someone to, I had a little property but it was going to need to be, made wheelchair accessible. So I needed a contractor who was an expert in making physical spaces accessible. I contacted the local Center for Independent Living and say, do you have a list of contractors who are particularly good at this kind of thing? And they did.
They're excellent resources. And in the chat, I can look up, there's a directory where you can find the one in your area, and I can put that in the chat. There was another question that's a little bit different, and just mentioning that as I've aged, I've had a lot of difficulty getting my family members to understand changes in my mobility, because I went from walking to using a wheelchair by the time I was in my early 20s. And some of my family members just don't understand the change and haven't always been accommodating.
Wow. Is there any particular individual on the panel who wants to field that one?
I think that goes back to the conversation that we had earlier, even in our other panel discussion about the self-advocacy piece of it. I think that's important to being able to communicate those needs. I still use crutches, but I transitioned more to a chair in my early 20s. I was on my crutches and fell off my porch and twisted my knee and wasn't the same ever since. And so it was more of my mother's house today. When I go to visit her, back when I could visit her, is not wheelchair accessible. So she said, I'm not going to make it wheelchair accessible because you need to be using your crutches when you come to see me. So, it's being able to communicate when that's not really something that is possible is, okay, let's see how we can come up with a plan to make this work. And so I think that open communication is an important part of that. And how do we even start that conversation? It depends on your level of comfort with who you're speaking to, but I think being able to have a plan in place when you talked about, and we talked about this in other sessions, and some ideas is one of the first best starts to help working towards, like I do with my students. I'm not going to do things for you. We're going to come up with a plan together to figure out how we can move forward. So.
Yeah, I think this is a tough one. And, sometimes the blunt method is the best one. My brother and sister-in-law invited me to come to visit them at their ski condo in Vermont. And I said, I can't. I'll see you when you come back down here. But I can't visit you there because I can't live in that space. I'm not able to do that anymore. And I think that's what he needed to hear. He needed to hear it that way. I'm sorry, I can't come visit you.
Yeah. And just like you said, like that blunt way, right? And so, yeah, I think that we're going to have lots of good questions for the session later on this afternoon on like retiring and sort of like what things to keep in mind as you stop working. Because yeah, lots of questions on retirement.
And I saw somebody chime in about ABLE accounts. You should
Yes.
be looking into you should be looking into that option in your state as well.
Right. And also one thing too that I just recently learned about, and please anyone correct me if I'm wrong, but that it does take Medicare, Medicaid about 5 years or so to for it to kick in after you retire.
Yeah. So the last thing so the last thing I'm going to say, the way I'm going to close out this session is to say, getting old sucks, except if you consider the alternative.
Yes, absolutely.
But planning now for how your life is going to be for the rest of your life is going to depend on the comfort level you're going to have. So starting where you are now to prepare for the future is important.
Yeah.
I think it's never too late to start planning ahead. Even when you're a millennial myself, it's always great to start planning now. That way that the more planning you have in mind, the more prepared you are in the future.
Yeah. So thanks everybody. We appreciate your time. I see we are at the top of the hour and we're about out of time. But as I said in the session we did with the younger adults earlier, we could go on with this conversation all day. All of us could talk about this. And so SBA is watching and they're listening and they know that we need more conversations like this to be facilitated, and we need more information. We need more collaboration, and we will continue having this conversation.
Yeah. Thank you so much. You guys are all, it was so good. And then just to say too, we have a YouTube channel. I'll put it in the chat, but there are a lot, that YouTube channel has a few webinars. And one of them does deal with ABLE accounts, with pooled special needs trusts. And moving forward, we're planning on putting together more information about financial planning and retirement, et cetera, because we know that it's so important. So just be on the lookout for those things. And I'll put the YouTube channel link so that you can all see it. Yes, for the agenda for the rest of the day, it is, if you go to the registration page, I'll put the link in the chat as well. You can just open that up and you'll see the agenda.